Next, we have Dr. Reshmi. She is a cornea specialist working at Fort Hospital, Trivandrum. She will talk regarding the suturing tips in cornea scleral wound repair.
Thank you, Regina, and thank you to KSOS for giving me this opportunity. So I'll be dealing with open globe injury, or actually corneal tear repair. So the principles that we follow generally is a restoration of the optimum visual function, restoration of anatomical relationships like limbus, and with a watertight closure, removal of any anterior segment foreign body that we see, prevention of glaucoma, amblyopia, infection, or the need for a secondary reconstructive repair. That means that when we do the primary corneal tear repair itself, we have to achieve as much as perfection and cosmesis so that we can decrease the scarring and the amount of astigmatism that later goes in. Of course, we need the proper prepping of the patient whenever required. We need a general anesthesia, and adequate antibiotics, both topical and systemic, should have been started even prior to taking the patient onto the OT table. So this is a video about how a corneal tear repair is done. So first of all, we under asepsis place a wire speculum. If it's a small corneal laceration with a formed anterior chamber, then we don't have to even enter the anterior chamber. We can directly go on to suturing. If it's a less stable wound, with a shallow anterior chamber, then we have to form the anterior chamber with visco. That is, we have to first place a side port. So here, while placing a side port, I want to emphasize something is that you don't have to place a side port at a particular clock or anything. The basic thing is that you have to place it where you are comfortable and the instruments reach the corneal tear. And if sometimes it's difficult to place a side port initially in itself, so what we can do is put the visco in through the corneal tear itself and then put the side port properly and then put adequate visco later. So first thing is we have to then wash thoroughly both the exterior and the anterior chamber with Simcoe cannula, and then inspect the wound for any foreign body or inspect it for any foreign body or iris incarceration. If there is iris incarceration, 2 points that we have to deal with here is, first, before repositing it, one thing is if it's a necrotic iris, you should just do abscission and do not reposit it. And if it's a healthy looking iris, then again one thing is there will be an inflammatory membrane on it, which you should have to probably peel it off and remove it before prior to repositing it. And after that, of course, there's a suture placement, which we use 10-0 nylon suture with fine spatulated design, interrupted sutures about 1.5 mm long, 90% depth, neither deep nor shallow it should be, and avoid visual access as far as possible. And we use a no-touch method, that is, as far as possible, do not touch the corneal tear edges. Coming to two different types of wounds that we usually deal with is the perpendicular wounds, in which the external wound corresponds to the internal wound, in which the only thing that you have to be careful is the corneal tear, the suture should be equal length on either side of the tear. That is, in the picture you can see the A is equal to B. This is the right way of placing it. But if you have a shelf wound, for example, if you cut a cake in a sliced way, you have an external wound somewhere, but the internal wound, lip would be somewhere else. In this case, A is equal to B is not what we have to follow. We have to look at the inner lip, and there is where the suture should be on either equal on either end. That is, in the marker shows which is the right thing. Coming to the different types of tears and which suture you have to place first, that's very important. So the first one is a linear laceration, in which you have to place a central suture first, and if it's in the pupillary axis, then don't place it in the pupillary axis, but on either side of the pupillary, straddle it on the pupillary axis. If it's a gaping laceration, it's difficult for us to approximate the thing and know which is the center. So the best thing is start from one end and then work towards the other end. If it's an angle laceration, then close the acute angles first and then only go to the rest of it. The rest of it I'll be dealing in separate slides. One more thing about linear laceration is we generally use a Rousey-Hayes technique, in which in the peripheries we put long compressional sutures, that is with a good suture tension, and in the center, as we move towards the center, we put short, just appositional sutures. So the thing is, when we come to the center, the peripheries might get loose. So go back and redo those sutures. You have to take adequate time and redo the sutures. There's no problem in that. And of course, bury all the sutures away from this pupillary axis. Coming to two situations where you don't generally require sutures, lamellar tears, in which case you can just do patching or even bandage contact lens with antibiotic coverage. But again, 2 points over here is, if you see a foreign body like this, then you have to remove it as well as wash under that lamellar tear. And another thing is, if you have a thick lamellar flap, then probably you have to put one suture so that properly opposes. If it is a corneal tear less than 2 mm, then you have a BCL with or without synovial glue is adequate. The stellate tears are one difficult way, tear to manage. So usually we follow the Atkins method, that is just crisscross sutures across the wound, and if required, if to get watertight closure, we have to put a bandage contact lens in the end. But ideally, Eisner's method is the one that you should use, in which you have to actually place intralamellar, partial lamellar incisions in between these leaflets, and then thread the suture through these lamellae and through the leaflets of the corneal tear, and finally tie it in the end like a purse string and bury it in that lamellae. So this attains good closure and less astigmatism. Coming to corneoscleral tears is a very common thing, and you know the first important suture to place, the limbal suture. Take your time and approximate the limbus very carefully. The rest of your job becomes easy then. Corneal wounds, we discussed about it. Coming to scleral wounds, slightly different. We have to use a better suture, like a thicker suture, like 7-0 or 8-0 Vicryl. We have to do a limbal pertomy in all cases of a limbal tear to see if there is an additional scleral wound and see the complete extent and close it. But suppose you have a case like the one on the where you don't know what's happening behind that hemorrhagic conjunctiva, then it's difficult to find the complete extent, in which case you explore as you go. So you see a scleral tear, you close it, and then you further explore and see the scleral tear. One additional technique that will help here is to leave the preceding suture long, so that you can use it as a bridle and push it down so that you can see further posteriorly. And also the help of an assistant is required, because if you have an uveal prolapse here, then it's best not to cut it, but rather just push it inside with a blunt instrument and suture it. Here you don't have to follow the no-touch technique, but rather you have to hold the scleral edge tightly and then do the suturing. If there is vitreous, anterior vitrectomy is required. If the tear goes under the muscle, if you are trained enough for that, then disinsert, repair the defect and reattach. But if you're not, then probably you can take it for a secondary closure. All scleral tears must also be buried, and conjunctiva should be closed with an 8-0 or 9-0 Vicryl. Coming to tears with necrosis or tissue loss where it's difficult, it's just cheese wires. In those cases, you have to plan a Prash graft in the primary setting itself, if possible, if you're in a center like that, or you can actually do a Tenon's grafting also. Post-operatively, these patients should be given adequate topical and systemic antibiotics, and in some cases antifungals also. Topical steroids is questionable, at least in the first few days, with there's a risk of infection, but after a while you have to start it. Meanwhile, you can actually give systemic steroids and cycloplegics. Visual rehabilitation, we plan for visual rehabilitation after 3 months, because once the sutures have all come off, and while removing sutures also, first only alternate sutures and then only the complete sutures. And once that is removed, you have to actually give spectacles, or in many cases, corneal astigmatism, then you have to give a contact lens like RGP or a soft contact lens. And if it's really scarred cornea, then you have to go in for optical keratoplasty. Thank you.
Thank you.